Hey everybody, this is Steve Carroll, and you're listening to the EM Basic Podcast. Today we're going to be doing something completely different. Today is the first ever screencast on the EM Basic Podcast. This is a presentation that I've titled Airway Update. Now, as a background, I actually prepared this about 2 years ago for a conference that unfortunately was canceled due to lack of funding. But I've kept this around because I think that it displays some of the very basics of Airway. And while this is not cutting edge stuff, this is stuff that we've been talking about for a few years. If you're a medical student or an intern just starting in emergency medicine or any other specialty, then this is a really great review of kind of what we've been talking about for the past few years in the airway and foam community. So I have a few other titles for this presentation besides Airway Update. My other title is The Best of the Airway Literature, the Web, and Social Media, Beyond 20 of Etomidate and 100 of Sucks, because we'll be going a little beyond the basics here. And finally, Ketamine, the solution to all your airway problems. So as always, I always have to mention that this podcast doesn't represent the views or opinions of the Department of Defense, the U.S. Army, or the Fort Hood Post Command. So let's talk about a few cases here. These will kind of help frame our discussion of what we're going to be talking about a little later. So first of all, that 70-year-old female who's got pneumonia and severe sepsis, her oxygen saturation is 80%. How are you going to prevent her from desaturating when you do an RSI? The 60-year-old male with COPD who's combative, how are you going to properly pre-oxygenate this patient to ensure he doesn't have a brachysystolic arrest when you do his RSI? 20-year-old male trauma patient with failed airway, how are you going to be able to get that surgical airway when you need it? The 50-year-old male with upper airway obstruction from a foreign body, what are the other options that we can do besides RSI to help get this person an airway? And finally, 6-month-old former preemie with severe bronchiolitis who needs intubation. Who's going to be the best person to do this? A pediatric emergency medicine or a general emergency medicine person? And finally, the VL versus DL, great debate. We'll wade into this just a little bit. So first off, this is the must-read airway paper of 2012. Now, I know that's 2 years behind, but this is still very relevant to what we do, and you need to go and you need to read this paper. Fortunately, it's available for free on the Annals of Emergency Medicine website. I'll put a link in the show notes. So this paper kind of really changed a lot of what we do in airway management in regards to pre-oxygenating the patient. It was written by Scott Weingart from the MCARE podcast and Dr. Richard Levitan, who's very famous in the airway circles for all his work that he's done with airway. So we're going to talk about a few big points of this article, but I really encourage you to go read it online for yourself. It's a really quick read. It's very high yield. So first of all, big point number one. We have always been taught that the non-rebreather mask is 100% FiO2. Well, guess what? It's not 100% FiO2. It's more like 60 to 70% FiO2 when it's used at 15 liters per minute. So what's the solution to this? Well, you take the oxygen regulator on the wall and you crank it to 11. Now, I don't even really remember this movie, but supposedly that's a joke from the movie This is Spinal Tap. So if you crank that regulator to 30 to 60 liters per minute, you'll get more like 90% FiO2 instead of the measly 60 to 70% you were getting before. This will help you pre-oxygenate your patient before you go to intubate them. The next big point here is that you want to have the patient properly positioned before you intubate them. So here's the classic photo that I think just about everyone has seen floating around the internet. I kind of wonder whether this patient knows how famous she is in the airway community. So this patient is obviously a very large female, and you can see when she is lying completely flat that she has a lot of weight kind of pressing down on her airway from her chest area. However, when you ramp her up, and this is obviously a very extreme example, but when you take a bunch of towels and blankets and you ramp her up, you're able to see that suddenly you take all that weight off of her chest. And the other key here is that her ear and her sternal notch is aligned. And you can see this right here. This allows her airway to be much better anatomical alignment and allows us a much better pre-oxygenator. Now, in patients who have a suspected spinal injury, you're going to want to use reverse Trendelenburg. So keep the bed straight, but then put that head of the bed up. Big point number 3. So first of all, the choice of paralytics. And here's what it's come down to. Rock rocks and suck sucks. So there was an OR study, and what they did was that they gave patients a sedative followed by either rocuronium or succinylcholine. And then they looked at how long it took for the patient to desaturate to 95%. So for normal weight patients, the difference in time between rocuronium and succinylcholine was 378 seconds versus 242 seconds, or a difference of 130 seconds. So the bottom line here is that you got 2 extra minutes if you used rocuronium of safe apnea time compared to succinylcholine. For obese patients, the difference was 329 seconds versus 283 seconds, so 46 more seconds. When was the last time that you did an airway? And think back to it. Wouldn't it have been great to have an extra minute or two of safe apnea time before the patient desaturated? I mean, this is pretty big. The theory here is that succinylcholine, in the process of depolarizing, actually chews up oxygen from your bloodstream. Big point number 4, and this is the concept of no desat. It's very simple, but it'll really help you out. And what no desat stands for is nasal oxygen during efforts to secure a tube. And basically what this is that you put a nasal cannula on the patient at 15 liters per minute before and during your intubation. So this is pretty easy. You set up the patient with a nasal cannula and a non-rebreather mask over it to pre-oxygenate them. Now, before you actually give them a sedative, you can consider not cranking up the nasal cannula to 15 liters per minute. No one's eyeballs will blow out of their face at 15 liters per minute, but it may be a little uncomfortable. I've tried this on myself, and it really just tickles a little bit in your nose. But you can keep it low until you actually go to intubate the patient. So once you've given the sedative, you want to make sure to crank up the nasal cannula to 15 liters per minute and do your intubation attempt. What happens is that the oxygen from the nasal cannula will passively diffuse into the patient's lungs and into the patient's bloodstream. So while the patient is not breathing, you're giving them a supply of oxygen. And this will keep their oxygen saturations up. I've been doing this for about the past 3 years, and in those 3 years, I have not had one patient desaturate on me during an intubation attempt. And I think we all know what used to happen before we started using this technique, is that you would go try to do your RSI attempt, and even though you would get the tube in quickly, the patient would transiently desaturate down to maybe 90%, 80%, 85%, but then would come right back up. If you do this technique, most patients will not desaturate at all, even with minutes of apnea time. And the science cat says it's so simple, and it really is, and you really should be using this. So here was a very interesting study that was mentioned in this paper. So this was a bunch of quote-unquote Navy volunteers in about the 1950s that they volunteered for this, allegedly. They went to the OR, and they were given a sedative and intubated, and then paralyzed with vecuronium. What they did was that instead of hooking up to a ventilator, they just put oxygen passively diffusing at the very tip of the endotracheal tube. So the patients were getting oxygen, pure oxygen, but they weren't actually getting ventilated at all. It was just passively flowing. As you can see, the patients, as you would expect, the pH of the patients dropped pretty low. They got pretty acidotic, down to a lowest of 6.72. So you would expect that for a patient who's not ventilated at all. However, and of course their PaCO2 went up. However, look at their oxygen saturations. The lowest anyone's oxygen saturation ever got was 98%. And look at these times here. I mean, 18 minutes, 30 minutes, 55 minutes with no ventilation whatsoever and no drop in the oxygen saturation. I mean, this is a pretty interesting study that, of course, would never get an IRB through an IRB today. But, this shows you the power of apneic oxygenation. This is an Airway video that Dr. Levitan showed in some of his courses, and there was a point to it that I'll talk about at the end, but this is basically one of the most awesome Airway videos ever that I just wanted to show.
فاتحة يا الله يا الله يا الله.
Wait for it.
محمد وآل محمد. صور أنا أستاذ.
So obviously, in whatever country this was shot in, they don't have HIPAA the same way that we have HIPAA here in the United States. So there was actually a learning point to this. You can find this video on YouTube. It's actually called "Where's My 9/16 French?" And the learning point here is that if you watch the entire video is about 6 or 7 minutes long, and the patient is intubated during this entire time. However, you'll see that they really don't squeeze the bag at all during the 6 to 7 minutes, and you can hear that the monitors are going fine, and his oxygen saturation is doing fine as well. So this was a case of active oxygenation, but it was also kind of an interesting airway case, to say the least. Two other points that the article talks about is to look at the patient's initial saturation before you paralyze them for RSI. So if you pre-oxygenate the patient and they're between 91 and 95%, you may want to consider using non-invasive ventilation with CPAP or a PEEP valve with a BVM, plus or minus ventilation during the apneic period. Now, during RSI, we usually talk about not doing any ventilation whatsoever while the patient is paralyzed. However, there are patients in these lower oxygen saturations, despite pre-oxygenation, that may require some gentle bagging during the apnea period. The article then goes to suggest that if your initial sats are less than 91% despite pre-oxygenation, then you really should ventilate during the apneic period by giving very slow and easy ventilations. Next case, you have a 60-year-old patient with COPD. He's combative because he's hypoxic and hypercarbic. His sats are 70%. So the answer that we think here is that we usually do is to just RSI the patient. But remember, his sats are 70%. So let's say that you give the etomidate and you give the sucks. Or if you really want to, what I think is the better option, give them ketamine and give them rocuronium. But let's say you do this to a patient who has an oxygen saturation of 70%. I think we know what's at risk for the patient happening. This is what happens. They can have a brachysystolic arrest from their hypoxia. So how can we avoid this? This is another article by Scott Weingart. It was actually published in April 2010 electronically, and it's been talked about for a while. And instead of rapid sequence intubation, we're going to do delayed sequence intubation. So what this is, and this is how you can think about it, is that delayed sequence intubation is procedural sedation for pre-oxygenation. So these are patients that you have to actually give them procedural sedation in order to get their oxygen levels up so that you can intubate them. And here's the algorithm that Scott Weingart has posted on the MCRIT website. I'll put a link in the show notes, but this is taken directly from his website. So start up here. You have a delirious patient who's hypoxic. The first step is to give them ketamine, 1 to 2 milligrams per kilogram. Ketamine is great because it preserves the patient's respiratory drive, and that's what we want to do. So instead of just pushing our paralytics right here and going for it, we're going to use the ketamine and the fact that the patient has a preserved respiratory drive to pre-oxygenate the patient, preferably with CPAP. So we use the ketamine to get control of their agitation and relax them a little bit, and then we pre-oxygenate them with CPAP. We let them pre-oxygenate for a good 2 or 3 minutes. We give them the paralytic, wait 45 to 60 seconds like usual, and we intubate. So basically what we're doing is we're just inserting a delay here to pre-oxygenate the patient. Now you really can't do this with any other sedative medicine such as etomidate or propofol, because most of those will actually take away the patient's respiratory drive, and that's not what we're looking to do here. Another option, although this isn't really what you should be doing as a beginner, is that once you pre-oxygenate the patient, if they're clinically improved, you can try to monitor them and wean the CPAP PRN. And maybe you don't have to intubate them at all. However, if they get worse, then you just administer the paralytic and you intubate the patient. The key here is this 2 to 3 minutes, is that this gives you time to think and it gives you time to prepare. It gives you time to prepare all your equipment, all your personnel, all your medications before you do the RSI attempt. So there's no real rush a lot of times to administer the sedative, administer the paralytic, and go for it. You want to consider to yourself, you know what, is it worth it giving me a few minutes to pre-oxygenate the patient or just prepare for intubation if the patient's very combative for whatever reason? So this was a case from my own practice, and this was the first time I used DSI. Kind of an interesting case, and it's not the best case of example, but you'll see what I'm talking about. So I had a 50-year-old female come in priority 1 EMS to a community hospital. She's an asthmatic. According to EMS, she's agitated and tiring. She's on BiPAP. Her sats are 90%, so, pretty decent, but obviously concerning. So when she gets there on exam, she's sweaty, she's combative. It doesn't appear she's moving a lot of air, and she's wheezing all over, although she's pretty awake. Her sats are 95% on EMS BiPAP, but her respiratory rate is 40. She gets a Zopanex neb, Solumedrol, and 2 grams of mag, and she's just not really looking like she's turning around. She just looks awful. So at this point, I decided, you know what, I'm probably going to try to do a delayed sequence intubation, and I think I'm going to have to intubate her because she's looking really bad. So I give the patient 100 milligrams of ketamine IV. Right around this time, her husband comes in the room from the ambulance bay, and he tells me, you know, she has a history of vocal cord dysfunction. And I go, just after the ketamine got pushed. Well, here's what happened after the ketamine got pushed. Her respiratory rate went to 14. Her sats went to 100%. She's calm, she's quietly breathing, and she's not wheezing whatsoever. I weaned her off BiPAP 30 minutes later, and she was awake and talking and eventually discharged. Now, this isn't the best case example because vocal cord dysfunction is, you know, the treatment for vocal cord dysfunction is usually not ketamine and BiPAP. But she really did look like a crashing asthmatic. And if she had actually been a crashing asthmatic, the ketamine would have allowed me to properly pre-oxygenate her before actually intubating her and going down that route. Here's a much better example. Before I talk about that, the use of ketamine in this case led me to the creation of what I call the SETA, what I call the Carroll Emergency Treatment Algorithm, because I think ketamine should be used in just about all emergency medicine patients. Now, it's kind of narcissistic to name an algorithm for yourself or anything for yourself in medicine these days, so you can also call it the KETA, the Ketamine Emergency Treatment Algorithm. And you may have seen this floating around Twitter. I've published it before. So here's the first step in the algorithm. First of all, ask yourself, does the patient have an airway? If no, give them ketamine. Put it in an airway. Is the patient breathing? No. Give them ketamine. Intubate them. Do they have adequate circulation? No. Give them ketamine. Ketamine will actually increase your blood pressure instead of decreasing your blood pressure like most sedatives. Does the patient have acute pain? Ketamine works for that too. Do they have chronic pain? Ketamine. Do they need a procedure? Works great for procedural sedation. Is the patient agitated? Ketamine works great for agitated patients. Does the patient have suicidal ideation? There are actually small case series that have shown that ketamine can actually decrease suicidal ideation in suicidal patients. So why not give them ketamine? And finally, is the patient still in the waiting room? Give them ketamine. They'll stop complaining as much about their weight. Now, this next audio clip is from Dr. Cliff Reed from MRAP a while ago when was asked, what is his choice for controlling agitated patients in the pre-hospital realm? Take a listen.
Let's paint a picture. You arrive on scene and a 20-something-year-old male is being held down by cops and paramedics, but is still flipping like a fish. But I'm not hearing that. I'm hearing, "Excuse me, doctor, I have a lack of ketamine in my blood, and I'm gagging for a blue cigar, please."
So in that case, blue cigar meant endotracheal tube. So ask yourself the next time you see any patient, are they suffering from a lack of ketamine in their blood? So this next case of DSI, I think, is a much better case. So you had a 50-year-old male in the ICU, and where in one hospital where I work, ER docs are actually called up sometimes to intubate these patients in the ICU. So he's a 50-year-old male. He's combative. I don't know why, because I'm just called up to intubate him. And his sats are maybe 70%. No one knows because we can't get a good pulse ox tracing on him. His GCS is somewhere around 5, so he clearly needs a tube. And I arrive to what I say is a cluster F in progress. I mean, everyone's just running around the room like chickens with their head cut off. Cliff Reed would call this a chicken bomb. So I arrive there and everything's kind of very disorganized, and they're very worried about this patient. Nothing's really set up to be for the intubation. So here's what I do: I give the guy 100 milligrams of ketamine IV. He immediately chills out. Everyone relaxes in the room. I take my time. I properly pre-oxygenate him. I prepare the room, I give him rocuronium, and it was an easy tube with no DSATs, despite the fact that this guy was about 350 pounds and actually had a pretty anterior airway. But it went very well because I gave the patient that sedation. I took away all the stress in the room with the ketamine instead of just rushing into an RSI like we would in the past. And basically, you look like a rock star when you come into a room and you take the chaos and make order out of it. So that's great too. So this is a little stupid airway trick. So pop quiz. This photo came from which 4 places? Direct laryngoscopy, an NP scope, video laryngoscopy, or an iPhone? Well, I think you guessed it. This came from an iPhone. So this is Trauma Gas Doc on Twitter. He's a British anesthesiologist, and obviously, this may be something that you may want to try at home. Just try not to bite down on your iPhone, and try not to get it stuck. You don't want to end up as the next person in the ER needing a crike for their upper airway obstruction from your iPhone. Next case, 30-year-old male. He's 300 pounds. He's in an unrestrained MVC. His GCS is 8, and he's combative. You've tried attempts at DL and VL. His SATs are 70%. It's obvious this patient needs a surgical airway. You could have also tried a supraglottic airway, but let's say that failed as well. This patient needs a crike. So whenever we think about a crike, I think this is what we see: a nice, clean surgical field. There's not really a lot of blood or anything else. But I'll tell you, in an emergency situation, this is what it looks like. Blood is everywhere. So how can we take this procedure that's very bloody and use something to make it go better? Basically, we need to think of a crike as a blind procedure. Okay, you're not going to be able to see structures. You're going to have to do this pretty much all by feel. So, in a case where you have to do this all by feel, how can we absolutely make sure that the tube ends up in the right place? Because it's actually a lot easier than you think to put it in a false passage and put it in the soft tissues of the neck. So this is a great technique called the bougie-aided crike. And basically what this is that this is using a bougie to ensure that you actually have, that your incision goes into the cricothyroid membrane and that you actually have a passageway into the trachea. And this works great when there's a lot of blood and everything and you have to do this blindly. So this is a video by Dr. Darren Broad, and I'll put a link to this in the show notes. And these are just a short snit, two short sections of this video where he demonstrates how to do this technique.
We proceed to our 1.5 to 2 centimeter transverse or horizontal incision through the cricothyroid membrane. We immediately place our finger into the opening to both save the location and bluntly enlarge the incision. We carefully set our scalpel down, take our bougie with the coude tip pointed towards the feet, place it into the incision, passing it towards the feet, feeling for tracheal clicks, and then hold up.
So obviously this is done on cadaver, so there's no bleeding, but it really kind of shows you the technique. This is how to then place the endotracheal tube over the bougie.
Once the bougie has been placed and tracheal position is confirmed, we can safely let go. Our landmark is preserved. We then take our endotracheal tube, in this case a 6-0 tube to fit over our bougie, and pass that into the trachea. Some pressure and a slight back and forth motion may be required to gain access to the trachea. Once the balloon is completely inside the skin, this tube is deep enough. At that point, we can blow up our balloon and we can withdraw our bougie.
The great part about this technique is that you can use the bougie as a placeholder. So once you know that the bougie is in there, you know that it's in the trachea, it serves as a great guide for the endotracheal tube to make sure that it goes in the right place. Our next case, a 30-year-old male. He has a psych history, and he has a foreign body in his airway. He's got stridor, and his SATs are 90%. And this is his x-ray. And what the freak are you going to do about this? I mean, that is a rock in his upper airway. On a more reasonable note, what about this guy? He has his dentures basically straddling his airway. So you have a few options here in these cases of upper airway obstructions. These also include when I say upper airway obstructions, we also think of angioedema or a Ludwig's angina or anything that's obstructing the airway besides a foreign body as well. So our options are is that we can give the patient etomidate and sucks, and we can pray that we get the tube in on the first try. You can take the patient right to the OR, or you can have a third option.
Ship my pants? Right here? Ship my pants, you're kidding.
You can ship your pants right here.
Or you can ship your pants. So let's have a talk on why RSI is not always the answer to every airway situation, because I think this is important to talk about. Now, this is a video that I had made a few years ago. This is when I was skydiving. I ended up with about 230 jumps before I had to give it up because I wasn't skydiving enough. But it was a hobby of mine for a while, and you can use skydiving to teach us some lessons about airway management. And Dr. Levitan has published on this before. So this is your average typical skydive here. Nice and blue skies. There wasn't a lot of wind that day, and you can see me as I tried to struggle to get into that sitting position that I was trying to do with the coach that jumped with me. So here's one of the screenshots from that, and here's the thing I want you to consider about me going skydiving that day, is that I jumped out of the plane with a whole bunch of equipment. I had a main parachute that I packed, and then there was a reserve parachute. The reserve parachute has to be packed by a rigger every 6 months who's certified by the FAA so that you know it's going to work if you need it. I also had 3 altimeters. I had a digital altimeter on my wrist, an analog altimeter that didn't require any batteries just in case the digital one crapped out on me. And then I had an audible altimeter in my helmet just in case I wasn't able to see the 2 altimeters on my hand. So I had 3 different altimeters so that I knew exactly what altitude I was at when I was jumping. I also had on a helmet in case I hit my head on the way out of the aircraft or with another skydiver. I also had a hook knife just in case I had to cut away my main parachute in case I got entangled with someone else. And finally, I had something called an automatic activation device. So if I was still at free fall speeds at about 800 feet, the automatic activation device automatically cuts open your reserve parachute. So even if you're unconscious and you're falling through the air, your parachute will open. You may land a little hard, but you'll survive. But here's the most important thing I had on that day. I jumped from 13,000 feet, so I had altitude. I had time. If something went wrong, I had time to fix it. Okay? Here's a much different situation. This is a base jump at night. I'll let you watch it. Now this to me is just scary. The reason why is because this guy couldn't have been more than maybe 200 feet up in the air. Maybe 300 feet, I don't know. I'm not sure exactly how tall this building is. But the reality is that he had seconds from him jumping off until he would go splat on the pavement. If anything went wrong, even the slightest thing went wrong with his parachute, he's dead, like right away. So what I like to say is that an RSI in the average ED intubation is like your average skydive. Yeah, there's some risk to it, but there's not a lot of risk to it, and most of them go just fine. However, if you have an RSI and upper airway obstruction, that's like doing a base jump at night. If you make one false move or you can't get something secured very quickly, the patient's going to crap out on you and possibly die. So here's an option I want you to have in your armamentarium for upper airway obstruction. This is a case report that described an awake surgical crike. I think that we always think about cricothyrotomies as something we do as like a last-ditch attempt when everything else has failed and the patient is, almost about to die. But, maybe there's some times where we need to go to the crike as the first option for an airway. So this was a 24-year-old male who had a self-inflicted gunshot wound to the face. He had 1 liter of blood loss prior to arrival. The tongue and floor of his mouth were swollen, and the team thought that it would be impossible to intubate him from above. He had stable SATs and blood pressure, but he had cool peripherals, so this guy was in a little bit of shock. So what they did was that they applied local anesthesia, they performed an awake crike, and then they gave him ketamine to calm down. I'm not sure why the ketamine came last. It probably should have come first. But basically what you can do for these patients is that you can pre-inject their cricothyroid area with lidocaine with epinephrine to decrease the bleeding and also give them some anesthesia. You can give them ketamine to calm them down but preserve the respiratory drive, and then you can perform the crike as a primary way of getting the airway. You don't even make an attempt from above because you don't think it's going to be successful. This is instead of getting yourself into trouble with an upper airway obstruction, why not just choose to do a crike up front? This is not something you're going to use a lot, but it's an option you should have in your back pocket. Another option is called the double setup. And this is from Emergency Medicine Updates by Dr. Ruben Strayer. You can find his stuff on emupdates.com. It's a great website. He doesn't publish very frequently, but when he does, they are really great posts and really great things in emergency medicine. So here's the idea of a double setup. This is a patient that they're looking to intubate, and, well, obviously this is a demonstration. But what you have here is that you have two people who are trying to secure the airway from above, but you also have a third operator here who has the neck already marked here for a crike and has a scalpel in his hand and is ready to perform a cricothyrotomy at a moment's notice. So there's nothing saying that you can't take a look from above if you think that there's at least a little bit of a chance that you can secure it. But if you're going to do that and someone has an upper airway obstruction or an anticipated difficult airway, you should make sure that you have this person at the patient's right-hand side marked and ready to go for a crike if the patient decompensates. So this is just kind of another option that you can use if you think that there's at least a small possibility of getting the tube from above. So his other question is, where the heck is your scalpel? He's a big advocate of carrying around a scalpel, and this is something that I do as well. So his argument is that, whenever you're looking to do a critical procedure, such as a crike or maybe even a chest tube, if this is something that comes up in a moment's notice, you don't want to be searching around for a scalpel. The post that you did on this also raised some other questions, like, where's your BiPAP? Do you know how to patient had a Brady systolic arrest. 11 of the 15 central lines that were placed were done by non-ED providers. 63% of their attendings had 0 intubations, none, in 1 year. The pediatric emergency medicine fellows had a median of 3 critical procedures per year, and 40% of them performed 1 or fewer intubations throughout this entire 1 year. So this really begs the question, how are we going to be able to teach these critical procedures in pediatric patients where our numbers are so small, even at a large children's hospital? It's a challenging question, and I don't think anyone really has the answer to it. So finally, the great debate, DL versus VL, direct laryngoscopy versus video laryngoscopy. And this really kind of kicked off a lot a few years ago when Dr. Ron Walls, who's a big airway researcher, said this on MRAP.
Gotten to the point now where we could unequivocally say, and I will unequivocally say, that I think it is wrong for people to practice direct laryngoscopy in 2012, given the obvious and proven superiority of video devices over conventional direct laryngoscopes. And I guess we'll come back probably and talk about that too.
I know that some of you just...
So that kind of started a big firestorm. People really kind of got fired up about that, and it really kind of started a big debate about what are the best ways to be teaching residents how to use laryngoscopy. Should we be using all VL? Should we still teach direct laryngoscopy? And I'm not really here to debate that fully, but I do want to give you a few pieces, a few things for thought. So this is why we love video laryngoscopy so much, is because look at this view. I mean, this is perfect. I mean, you rarely see a view this great with direct laryngoscopy. It's nice and centered. It's like a grade 1 view. I mean, this is what I call airway porn. I mean, this is beautiful. This is what you're looking for in every intubation. And this is what you usually get with a lot of the video laryngoscopy devices. However, it comes at a price. First of all, this was a very interesting study where they looked at GlideScope versus Macintosh laryngoscope to take out foreign bodies in an upper airway in a cadaver model. So they took 28 first-year EM residents at an airway course in Korea, and they randomized them to GlideScope versus DL for foreign body removal. They actually used a piece of sausage. So there was a 62% success rate with GlideScope versus 100% for the DL group. There was also faster extraction of the foreign body with DL versus VL. And here's why. So one thing that you have to realize is that with the GlideScope in particular, the blade of the GlideScope is angulated a lot more steeply than the Macintosh blade. And this is what gives us that great view. Now I'll do an overlay here to actually prove to you the difference. So if you can see the difference in these red lines, this shows you how much more angulated the GlideScope is compared to the Macintosh blade. So what this does, and this is another paper from Dr. Levitan, is that for the direct laryngoscopy, in order for you to create that sight line between your eye and the patient's larynx, you actually have to displace all this tissue. And this gives you a much straighter shot into the airway. It also gives you access into the airway to be able to remove a foreign body much easier. So it's a different technique, but it has its advantages. This is an overlay of a GlideScope in that same airway. You'll notice that the GlideScope kind of reaches around the corner. And this reaching around the corner right here can give you a great view, but then it can actually give you difficulty in passing the tube because then you have to make the tube go around this corner. And this is what we're seeing in studies that compare direct laryngoscopy and video laryngoscopy. For the video laryngoscopes, you get a great view, but then it actually takes you longer to pass the tube because of this great bend in the airway. Now, there are different systems. I personally like the CMAC system because it has a Macintosh blade on it that has still gives you the option to do video laryngoscopy, although GlideScope is coming out with Macintosh blades for their system as well. I honestly think that is the best of both worlds because you get that tissue displacement, plus you also get the advantages of video laryngoscopy as well. So my opinion is that we should still be teaching both techniques because there are room for both techniques in emergency medicine. Also, there are studies to suggest that whenever one technique fails, the other one usually succeeds in to be able to rescue it. So I think that we need to be facile at both direct laryngoscopy and video laryngoscopy. Finally, our take-home points. Let's wrap this up. So first of all, every patient, every time, I don't care where you are, what you're doing, give them no DSAT. 15 liters per minute through the nose and 30-60 liters per minute by non-rebreather mask. Just crank up the volume. Delayed sequence intubation. Give the patient ketamine, pre-oxygenate them, slow it down, and intubate them. Remember, this is procedural sedation to pre-oxygenate the patient. Upper airway obstruction. Keep in mind your bougiated crike. Go back to that video that I'll post on the show notes. An awake crike is also an option as well. And the double setup. Try to tent from above, but be ready at a moment's notice to crike the patient if you have to. And DL versus VL. I think there's a role for both, but if you're looking to take a foreign body out, DL is probably the best way to go. All right, guys, that's it for this podcast. I hope this was useful. I know this is way different from what we usually do in the podcast, but I was excited to be able to do this and be able to give you some info. If you have any questions, please don't hesitate to email me at steve@embasic.org. All right, guys, until next time, this is Steve Carroll for the EM Basic Podcast, signing off.